Hi, and welcome to another exciting episode of the Andre The Beast Crayton Show with my beautiful co-host, Yolanda L. Smith, the philanthropist. Wait a minute, let me finish.
Thanks, Andre. You guys, he's been feeling himself. We've been taping all day, and this is what you get, when you just don't know what to expect.
You don't know what to expect.
Yes, but today we have a lot to share with you. I mean, we have two very special guests today that are really amazing endovascular surgeons, and they're going to be bringing knowledge and so forth, because we feel like right now we need knowledge because we're facing a health crisis on many fronts. Today we're going to be focused a little on type 2 diabetes and how you can maybe manage your health and the populations affected by this disease. We know that we experience health disparities often within the minority communities, and so the things that these two are doing is nothing short of remarkable in helping to make a difference in the lives of many. So I want to welcome to the audience Scott Brannan and Dr. Marc, Dr. Scott Brannan, let me get that right, and Dr. Marc Eckausher.
Did we get it?
Did I get that right?
You got it.
I didn't say
Welcome to the show, guys.
Thank you.
Yes, and they're coming. We're remoting them in from Arizona, so I'm excited. Is it hot there? How's it feeling there?
It just started to get hot. Just a few days ago, it just started to get hot. It's not unbearable yet, but yeah, you can tell you're in Arizona now.
Yeah. So you guys are doing some really cutting edge things in healthcare as it relates to the prevention of amputations and things of this nature. I would love for you both to just take a couple minutes each and then just share with the audience a little bit about yourself so they'll know who we're talking to. And then, we can get into literally what you guys are doing and how it's making a difference and how medicine is being viewed today, particularly as it relates to diabetes and amputations.
You want to go first, Scott?
No, sir. I defer to you.
Oh, wow. Okay. Well, I'm a vascular surgeon, and I've been doing vascular surgery now for about 40 years. I trained in Cleveland at the Case Western Reserve University and became an associate professor there and taught both general and vascular surgery to the residents. At the time I finished in my training, there was no real endovascular surgery. So over the course of the years, I took time off and I went and learned from some mentors about endovascular procedures. And then subsequently, after leaving the university, after teaching there for 11 years, went to Southern Ohio, where I opened the Northwest Ohio Vascular Institute and started the endovascular program there. And then subsequently came to Arizona and have been practicing endovascular here since 2000. And what I'm most proud of actually is the self-training that I've gone through to learn the newest techniques in endovascular and feel that I'm on the cutting edge right now. I've actually worked with Dr. Brannan now for a year, but he knew about me long before that, which makes me feel very old.
It's okay.
And so I was really doing both open vascular surgery, bypasses, things like that, fixing aneurysms, and doing also endovascular. Now, because of the skills that I have, 95% of my practice is endovascular. And what I've added into my practice over the years is the revascularization of the foot below the ankle, which I feel is one of the most important parts of vascular surgery and preserving limbs. And of course, Dr. Brannan and I have a lot of fun together. We do very complicated cases, and we support one another. And neither one of us is unwilling to accept constructive criticism and advice on how to proceed with a case, which I think is really important. You can't have so much hubris that you feel you are the king and you are it, and then you proceed and you don't fix what really needs to be fixed. My feeling is that no patient ever comes to be treated and leaves in worse shape. They either get better, or if there's something I can't do endovascularly, I can always take them to the operating room and do something else. So I've had the greatest time since working with him. And the other thing that I'm really very proud of is the fact that I've become the chief medical officer, and now I'm actually the bridge between administration and clinical. Oftentimes, administrative mandates are harmful to clinical programs.
Understood.
And so I've been able to manage where there's a compromise now between administrative and clinical, so that the funding is there, or some of the mandates that come down are smoothed out, so to speak. The other thing that I'm most proud of is that I've also become a bridge between the insurance companies and patients.
That's going to be a good topic.
Yeah, I've been able to convince insurance companies, when they deny patients access to procedures, I've been able to convince them that this is something that's absolutely necessary. And then again, we've come to some type of compromise, and the patient gets the procedure done. So those are the things that really excite me.
Thank you for sharing. That's good. Dr. Brannan?
Hey, thanks you guys for having me on the show, having Dr. Eckausher and I on the show. And as you said, I learned about Dr. Eckausher when I was in medical school. He already had a great reputation when I was in medical school. And there was one specific conversation that took place that included his name. And then many years later, we wind up working together. It's a total, absolute 100% dream come true. That I never really thought it would happen. I approached Dr. Eckausher, I think 5 years ago, asking him to join the team. I got like a 3-word text message response, and nothing after that.
I'm scared to ask what the 3 words were. Are you crazy?
Not interested or something, but because he's a legend and he's done so much great work. And I was just, the work that I do and that we do is relatively pioneering, and it's cutting edge. And I don't even know what I was thinking, having the courage to say, hey, could you come join this practice with me, those years ago. And then, a few years later, we're joined up. So it's a huge honor. And what we focus on is specifically diabetic limb salvage. And really, I think that's the technical term that we use. But I prefer the term preservation, limb preservation. And Yolanda, you hit on it earlier about, the idea of trying to take care of ourselves and advocate for ourselves. Yes. So there's 2 different components to that. There's the health maintenance subject, which is, trying to control your blood sugar if you're a diabetic, control your hypertension if you're hypertensive, exercise, eat right. Those are all part of the health maintenance aspects. But there are times when even those interventions are either delayed or they're incomplete, and patients matriculate to the point where they are facing an amputation. And the thing that can prevent it is restoring blood flow to the foot. And in terms of advocacy, there are cases where either insurance companies or institutions or certain physicians are not in favor of that type of intervention, of restoring the blood flow to the foot and preventing an amputation. Because the truth is, many times, by the time we get to that point, we are dealing with a very ill patient, somebody who has a lot of medical comorbidities. And from the actuarial standpoint, just the sheer dollars and cents on the insurance company side, they're looking at it and saying, is it really worth the 2, 3, maybe 4 interventions this patient's going to need over the next year to save that leg? Or is it going to be more cost effective to amputate that leg and let nature take its course? And unfortunately, the course that nature takes after an amputation is lethal. The 1-year mortality rate for major amputation is 50%.
Wow.
Hey, Scott, let me ask a question. Let's go back a little bit.
Sure.
Give the viewers more about your background. And then the second part of that is, what are the percentages that we're dealing with when we're talking about diabetes among individuals? What are the numbers looking like? But first, let's go back and tell a little bit more about who you are and what you do and what led you to this specific area.
Sure. So I'm from Arizona originally, 3rd generation from Arizona here. And I grew up in kind of northern Arizona, right near the Yavapai Apache reservation. And most of my friends and teammates when I was growing up were Native American. And so I've always had a strong connection with the Native American community. I went to medical school, went to residency, fellowship, came out. And at that time, my mom and my stepdad were living on the Navajo reservation, working at a hospital up on the Navajo reservation. And I learned about the massive amputation rate that was taking place on the reservation. And for the tribes west of the Mississippi, what were originally termed the uncivilized tribes, meaning the Navajo, the Apache, the Arapaho, the Comanche, those tribes were sort of, that was the second kind of phase that the Civil War Army went through, right? You had the Civil War Army, and then those soldiers didn't just vanish. They had to have a second mission, which was to go forth and either exterminate or subjugate the uncivilized tribes of the West. And so those tribal communities were essentially rounded up and put into concentration camps that we referred to as reservations. And their normal ways of life were confiscated. Their normal foods were confiscated, and they were supplemented with cornmeal and high starch diet. So as one can imagine, the rate of diabetes in that population skyrocketed. And in a paper published in JAMA, the Journal of American Medicine, in 1982, which evaluated the Pima population, which is near to Phoenix here, they discovered a prevalence of type 2 diabetes in tribal members 30 years old and greater of 50%. Half of the adults in the tribe had type 2 diabetes. Now, in 1982, in the general population, you're talking about an 8% prevalence compared to a 50% prevalence amongst Pimas. And the way that diabetes manifests, as everyone should be aware, and if you're not aware, please focus in right now. The way that diabetes manifests is usually silent. It is a silent killer, right? That's why you need to go get checked, because diabetes will cause symptoms that are not so severe that they stop you from doing your activities of daily living until it's gone very, very far. Once you get to the point where you're starting to lose your vision, right? You're starting to lose your renal function. You're starting to develop diabetic foot ulcers. The disease has already progressed very far at that point. So the other population that is similarly affected by type 2 diabetes is the African-American population.
Yes.
If you are an African-American diabetic in the United States, the likelihood that you will lose a limb is 2 times greater than anybody else. If you're a Native American with type 2 diabetes living on a reservation, your risk is 3 to 4 times greater than the age-matched and comorbidity-matched cohort. So the consequences of this disease are significant and potentially catastrophic.
Scott, you mentioned something about this. It's almost like a silent killer. So with that said, when most people, you guys been in this field for a while, what have you guys noticed? Did you notice that most people that have come to you are already in the pre-existing stage and have been in the pre-existing stage long before they came to you?
Yes.
So what happens with this?
So the recommendations for screening for diabetics have been around for 13 years, or actually 15 years now, and they're really not being followed very rigorously. Anybody who is 50 years old and has a diagnosis of type 2 diabetes should have a full vascular evaluation.
Okay.
So that we can start getting the disease earlier. By the time Dr. Eckausher and I are seeing these patients, many of them already have arteries that are completely closed and have been for years.
Wow. So Dr. Eckausher, I got a question. You had mentioned you started as a vascular surgeon and then you went over into endovascular. Can you explain for the audience, because we do have a lay audience, what does endovascular mean or the difference between the two?
Typically, vascular surgeons, up until several years ago, were trained in open procedures. So you would do a bypass in the leg if someone had a blockage, or if someone had an aneurysm, you would have a big operation, patient be in the hospital for 7 days. Or if they had a stroke in the past, you would clean out their carotid arteries. In the 90s, and this was pioneered in large part by Ted Dietrich at the Arizona Heart Institute, where I got my training. You started dealing with the same issues, but with a puncture, and then using wires and catheters and different devices to clean out the arteries. So the endovascular part is minimally invasive as compared to open surgery. Endovascular procedures pretty much is an outpatient procedure. The patient goes home the same day. Whereas if you do a bypass or an aneurysm repair or whatever, the patient's going to be in the hospital for several days. So in my mind, not only is it better for the patient, it's more patient-centric because the people care about the patients as opposed to large hospitals where you're just, going in and out, and it's more like just a business. You can get the same results. For instance, I used to do bypasses for occlusions in the artery in the upper leg, and we would use a prosthetic piece of material or vein. And then I started doing endovascular procedures, and the patency rates, in other words, how long the bypass or the endovascular procedure would stay open, was pretty much the same for above the knee. Once you had to do below knee bypasses, the patency rates, because you would have to use veins, so bigger incisions, longer hospitalizations, the patency rates dropped remarkably. They dropped into the 60% range. Mm-hmm. Currently, we get the same type of results with an endovascular approach. And one of the things that Dr. Brannan's done is he's part of a research project looking at potentially putting stents in the arteries below the knee to maintain patencies. And that's a multi-center study. So actually in the 90s, if you didn't learn and proceed with an endovascular approach, basically your vascular practice was going to become non-existent.
Okay.
And so I took that on myself. I trained with Ted Dietrich, and then went back to Ohio and started that whole program, and then came here.
Gotcha.
No. Scott, what is I get where you guys are going. You're definitely on a crusade to shine some light on this. But what is it actually? What is the reason that it's not getting the attention? What's the dollar ratio? Because it's all about money at the end. So what's the difference in the level of care with the Native Americans? Let's be real, versus our population. And because we know when it all boils down to it, it's a lot easier to cut somebody's leg off and let them die within a couple of years versus the insurance company handing out tons of money. So what exactly does these numbers look like, and how is it different from the Native American culture versus what we consider our culture?
So yeah, Andre, I think you're trying to cut straight to the quick on this. You want to get, because
we're like
because there's a lot of science and there's a lot of different roads we can go down. But yeah, Andre, you're trying to get to where's the beef on this? Where's the dollars and cents? Why is it that limb preservation hasn't had more of an impact than it has? Right. Why is it that when we know we have this technology available,
why isn't it being utilized?
Isn't totally penetrated, right? Like, for example, if we knew that we had some type of treatment that could reduce the mortality rate of breast cancer by, let's say, 75%, there wouldn't be any question about that, right? Yeah. It'd be like, bam, let's get that out there. When it comes to limb preservation and it comes to these procedures, there is unfortunately a calculation that takes place amongst insurance providers and amongst certain healthcare providers that, it's from a cost standpoint, it is going to be cheaper to cut this patient's leg off and provide them the very, very best support we can, give them a prosthetic, whatever. But knowing that even with the very best support, that 50% of those are going to be dead in a year. And you can set your watch by it that in 3 years, 75% will be dead. I can tell you that for sure, based upon unfortunate experiences of patients who do matriculate to major amputation. Now, with the IHS in particular, the Indian Health Service.
Okay, that's what it is.
Sorry, yeah, Indian Health Service, okay. Which was kind of an extension of the Bureau of Indian Affairs, which was an extension of the basically the Army, right? The Army that fought the Civil War turned into the Bureau of Indian Affairs, and the IHS was kind of created as a way to manage the medical necessities of enemy combatants. And so IHS over the years evolved into a healthcare system that is, quote unquote, separate but equal, right?
Hold on a minute, Scott. Go back to that word so people can understand how important this mission for you guys is. You use we already know what a reservation is. It's basically a concentration camp. Plain and simple. Let's call it like it is. It's a concentration camp. But you use the word that should frighten a lot of people. We use Civil War. We use Indian combatants. Explain that particular term in general to the viewers.
So IHS was a health system that was designed to address the basic needs of enemy combatants. The uncivilized tribes of the West were enemy combatants, and it was the policy of the United States government for many of those tribes not to attempt assimilation. Many of those tribes the policy of the United States was extermination. The Apache being the most well-recognized tribe. And the only way that the Apache prevented from being totally annihilated by Kit Carson and the other veterans of the Civil War was by retreating into Mexico and hiding in Mexico for years before they ventured back to their customary homelands, because it was the official policy of the United States government to exterminate that race of people, because they did not believe that they could be civilized. And so this is a real scar, an ugly part of our U.S. history that occurs after the Civil War, that occurs decades after the Civil War, that doesn't really stop until we approach 1880, 1886. That's the last time that we had an official extermination policy for Native Americans. And then we have a healthcare system, the IHS, Indian healthcare system, that is a well-intentioned system, believe me, well-intentioned, run by good people with good hearts. But the roots of that system come from a attempt to provide the bare minimum medical necessities to enemy combatants.
We're still putting,
and the stain of that continues.
Still putting a stronghold on the Native American people.
Well, the term separate but equal, right? That should raise the hairs on the back of your neck.
Exactly. That's what got me.
When you hear that term separate but equal, we as a nation decided that was not appropriate in the United States way back with Brown versus Texas, right? Brown versus Board of Education.
Mm-hmm.
Brown versus Board of Education said, if it is separate, it cannot be equal. There's no such thing. It's not separate but equal. Right. And we as a nation, we eschewed that policy many, many decades ago, except for when it comes to the care of our Native Americans. We continue to endorse and pay for a healthcare system that is separate, but quote unquote equal.
And this is definitely close to home for you because your parents grew up on the reservation. So you saw this firsthand, and the crusade is still going on to address this. What have you seen done just as isolated for a minute in the states that have the most reservations or concentration camps? What have you seen as far as numbers increasing with diabetes, medical care, healthcare, or has it basically still having has our policies still keeping a stronghold on the efforts to address this?
So this is actually part of the good news of the gospel of limb preservation that I'm trying to spread. There is hope. There are places that are doing well. There was a movement in the 1960s to allow Native American tribes to reappropriate some of their municipal functions. And it's Title 638 is what it's called. And certain tribes were able to take advantage of Title 638 to repatriate some of their municipal functions, including sewer, gas, roads, and healthcare, right? So that it wasn't that all these things, they weren't just begging for the federal government to come in and impose solutions that might not really fit.
Right.
And so under Title 638, the tribes were able to still get federal funding, but to administer those funds locally. Mm-hmm. And that has in some cases led to very significant advances in the quality of healthcare that's available. One of the examples here in Arizona is the Gila River healthcare system, which that was the population that I described. It had the article from the 1982 JAMA journal that showed a 50% prevalence of type 2 diabetes. They converted to a 638 hospital or 638 healthcare system in the early 2000s, I believe, maybe 2009. And the quality of care there has has increased massively because you have your own people taking care of your own people. It's not that IHS was ever evil or wanted to hurt people. It's just you can't take care of somebody that you don't know and love the same way that somebody who knows them and loves them can. That's just the facts. And so you have right here in the city, you have two healthcare systems. You have Gila River, right, which is a 638. And then you have Phoenix Indian Medical Center, which is a pure federal facility. And the pure federal facility to this day, at least as far as I know, and as far as I've experienced, their amputation policy is amputation first. So they don't have the technology or the physicians to provide the services that Dr. Eckausher and I provide. And that's not uncommon. Many reservations don't, but they will refer out to physicians that can attempt revascularization. And the Phoenix Indian Medical Center, which is the IHS hospital, if a patient comes in and they have infected bone in the foot, the policy is just to go ahead and remove that foot, just cut that leg.
Hey, Scott, but I'm all in too. I'm sorry.
That's all right.
You sure? I can answer. Okay. So Scott, let's get even more deeper because our show is designed to educate. And I appreciate you guys definitely being here to educate on a topic that is universal. This is a worldwide thing. But because me and you shared it, I had a friend that went in the hospital, good friend, and next thing I know, boom, week later, he's amputated. But there's something even more that people don't understand, and correct me if I'm wrong here. You're not just talking about amputee, you're talking amputating somebody or removing a limb. People need to understand the aftershocks that happen after this, the workload that this puts on the heart, and the fact that the mental aspect of it, because most of these amputees and diabetics are already pre-diagnosed before they even walk in your office. So now you're telling somebody, let me cut your leg off, let me cut your foot off, let me cut your finger. Oh, don't forget, we got to treat you mentally so you don't go out and commit suicide, because this is a total readjustment. Am I misleading something here? If so, clarify.
No, Andre, you hit it dead on. I mean, if you think about what we do with, I know I had the honor of working at Walter Reed Medical Center at the Armed Forces Institute of Pathology there when I was in my residency training. And so we were able to work with the Wounded Warrior program. And those Wounded Warriors who come back with amputations, they are required to participate in 12 weeks of psychiatric or psychological counseling. The mental and emotional and spiritual aspects of amputation are emphasized. That for a diabetic who loses a limb, frequently it is a surprise. They wake up and their foot is gone.
That's what
they came into the hospital with an infected toe. They came into the hospital with an ingrown toenail. Mm-hmm. And they're on medication, they're on antibiotics, they're on some type of a sedative. You know, they or a relative consents to a surgery, and maybe the surgery was intended to just remove that toe, but nobody went in to restore the blood flow before the surgery. And when they cut the toe off, there's no blood flow there and it can't heal. And so it goes to, let's cut the front half of the foot off. But nobody went in and restored the blood flow below the ankle like Dr. Eckausher was describing. And so that front half of the foot didn't have any blood in it. And so in that same surgery, all right, we got to cut that foot off. And patient comes out of surgery having gone into the hospital with an infected toe, and they have no leg left below the knee.
Isn't this, I hate to say this, but isn't this a crime? That is the exact same thing that happened to one of my best friends. He went in, and we shared this, Scott. He went in, I went to go see him. He had something wrong with his foot. He wakes up, his whole foot is gone. I mean, how do you tell somebody, well, what gives them the right to do that? I mean, is there guidelines? Is there principles? Or do the medical doctors say it's a lot cost efficient for the insurance company to say cut his foot off because he or she is not going to do what they're supposed to do to begin with?
There are many times that you'll see patients who have been to wound centers and they, have had a wound on their foot and they've been followed in the wound centers and they'll debride the wound and try and keep it clean and whatever. And I can't tell you how many times finally that patient shows up in the office and they have not had a vascular workup. And you do a vascular exam and you find out that the main artery in the thigh is totally blocked. Well, it isn't going to heal. There's just no way it's going to heal.
Okay.
So in those instances, if you restore what we call the inflow, and then you look at the below the knee and what's in the foot, if you're able to restore the outflow, then that wound has a chance to heal, because anytime you have a wound, you need more blood flow. You need more nutrients going to that area. And oftentimes what will happen is a patient might be sent for hyperbaric oxygen, where you put in the chamber and they try and under pressure get more oxygen into your blood or plasma, which is the other component of blood. It's not going to work. And then patients are put on antibiotics. Well, antibiotics aren't going to work unless the antibiotic can get there. And so oftentimes you'll see these patients, they spent months and months in a wound clinic. I just had a patient come in 2 years in a wound clinic. Nothing's been done, no vascular workup. And she is now going to end up being scheduled to see if we can't heal the wound that's in her ankle. Otherwise, she's going to lose her leg.
So, Marc, why do you think that she didn't get the vascular workup? I mean, that should have been the doctor's protocol. Isn't there a protocol to follow?
Well, I'm sure wound clinics have protocols. But what you see, the people in wound clinics are not necessarily vascular oriented. Let me put it that way. Okay. They kind of have blinders on and they're looking at the wound. And then also, as you've been discussing before, let's look at the cost.
Right.
Okay. A wound center, the only way it's going to get any kind of reimbursements, is if the patient keeps coming in week after week, getting a debridement, if they send it to me or Dr. Brannan or whoever, and you're able to restore the flow and the wound heals, that's a loss for them.
Yeah, this is kind of interesting. So this is because there are national guidelines for things, right? I mean, we know that there's a process. If you have an MI, you do this test, you do this, you do this. Where are we on trying to get some national guidelines around this? Because I just find it, I mean, I'm looking at this and I'm like, okay, somebody needs to get on the megaphone and start yelling. We've got to do something different. I mean, even if it was just a matter of requesting a vascular workup so that because the truth of the matter is that if you're giving all these other treatments and you don't really understand the root cause of what's going on here, talk about wasting money. I mean, if we're really about,
preserving money and saving
money in the healthcare system, that would be one way to do it. Now, I know that takes the money from other areas of being able to make money, but I thought the oath was to do no harm. So at what point do we say there's got to be some national guideline? I mean, like, where's the American Medical Association on this, or the Vascular Association on this, to really help you guys in the work that you're doing? That was question number one. Question number two, how prevalent is what you do across the country? And are there enough of you to really be able to make a difference in treating the way you're treating?
You've been reading my notes.
I didn't read it.
So if I may address that, Yolanda, Now, just to clarify, Andre and I had a brief conversation yesterday. There was no setup. There was no, I didn't know anything about Andre's background or his friend. But when I described the saga that is very typical for a diabetic patient who enters the hospital with an infected toe and then wakes up a few days later missing a leg, Andre sat up and was really paying attention. Like, man, that happened to a friend of mine, that exact thing. And I had no way of knowing that other than I've seen it happen 1,000 times.
I would be devastated. I'm just saying, if I went in and thinking maybe you're taking a toe, and I come out and my leg is gone, I would be devastated.
He was crying. I mean, I couldn't even imagine just I think he died from, I told Sky, I said, somebody told me he was going to die within the next couple of years. He died within the next couple of years, but I think he died because it was like they cut his foot off and was like, okay, go back to the world. How do you function after that?
I don't know.
Well, see, and that's the other thing, Andre. I hadn't even mentioned the statistics to Andre. I just said, and is he still alive? And he said, no, he died about a year later.
Yeah.
And that's not a setup. That's the facts. That's what happens. I didn't know that about Andre's friend, but Andre's friend absolutely proves the point. So if we just stick with that, with the bare basics, without getting into lots of clinical details, where are the guidelines on amputation prevention? And the fact of the matter is there are none right now. There are recommendations from different societies, but because there is this perception of competition between different medical fields, right? But if we followed the rules of the game right now, Dr. Eckausher and I would not be practicing together.
Why?
This is because it is very rare that an interventional radiologist, which is me, an endovascular guy, teams up with a vascular surgeon.
Okay.
Extremely rare. Right now, those two camps are opposed. And it's not coming, I can tell you it's not coming from the interventional radiology side. Here in Arizona, there are very few practices where the vascular surgeon and the interventional radiologist work together. There's 3 interest groups: vascular surgery, interventional cardiology, interventional radiology. We all 3 need to come together and have guidelines. And we attempted this 3 years ago. Excuse me, 2 years ago. There's another limb preservation missionary in Mississippi who you guys would love to talk to. And he and a group of us got together and worked with the Congressional Black Caucus to come up with a very simple request. A national guideline that simply stated, prior to any major amputation, a patient must have a comprehensive vascular workup. And that to me, that makes sense, right? And we even excluded trauma. We said, somebody comes in with trauma, and they got an at-risk limb that needs to go. Okay, no vascular evaluation necessary. That's a different situation. But somebody comes in with an atraumatic situation, and they need an amputation. Let's do a full vascular workup. Now, a full vascular workup doesn't take days. It takes, maybe hour, to do a full vascular workup.
What's the percentage of saving somebody that gets this done?
If we can restore flow to the foot, the rate of amputation reduces by about 75%.
Okay.
So the recommendation was very simple, and it wasn't intended as an offensive move by any one of the groups.
Right.
But all the pushback came from surgery. Because they said, you guys, you interventional radiologists, you interventional cardiologists, you're not in the ER. You're not getting the call when the patient comes in and they're septic. And you're saying we need to take our time and do a vascular workup, get an ultrasound or get a CTA. And this patient, we know they have a septic foot or they have a septic wound, and we need to cut that leg off. And
I told you that's what the first thing they said he had when I walked in there. Remember, he said he was septic, and I was like, "What are you talking about?" And they had me come out, and I was like, "Go ahead, go ahead." That's just
This almost sounds like politics. I'm getting
well,
matter of fact.
Andre,
How much is this is politics?
I mean,
Scott?
it almost sounds like our government. Just the way we can't even be.
Unfortunately, there's a lot of politics involved. But let me just say this. Everybody that I know that is involved in vascular care and that is interested in limb salvage, limb preservation, are people that are coming from their very best spot. They're not thinking, how do I make more money or how do I do less work, right? They're all coming from their very best spot in their heart. I know that. But it's a matter of education and being open. Many people will cling to facts that they know without looking further, without considering.
Evolve, right? Technologies evolve, medicine evolves. So, I mean, you can't just keep using the same Lasix pill forever if there's something else that shows that it's better. And that's just how I'm thinking about it.
This is the beauty of Dr. Marc Eckausher. You have a guy who's been doing surgery for 40 years, and who knows the facts, who taught the facts, who would tell you at a certain time, this is not possible.
So
and was open-minded enough to go, you know what, this is possible.
So do you think that they're keeping Marc quiet?
Keeping Marc.
So Marc,
you can keep Marc quiet.
That's impossible.
Marc might have the ability and the answers to really change the whole picture right now. And I think
Marc is one of many, but he's extraordinary to me because of my personal experience. But there are many surgeons out there who do this. There are many surgeons who are out there advocating against their own society to say, guys, we need to focus more on limb preservation, and we need to be less sure of our amputation first policy in certain cases. And so, Yolanda, we need advocacy. We need it so badly. We need people at all levels for their own family members. If there's anybody who's listening to this podcast right now, who within the next 20 years, which is how long it's going to take to get this fully penetrated. But if you have a family member who within the next 20 years is offered major amputation as the solution to their disease, you need to not sign the consent form and you need to ask for a second opinion. Yep. That is your right.
Let me ask a question since you brought that up. You or Marc can answer this question. You go into the doctor and you've been diagnosed with type 2 diabetes. As an individual, what should my protocol be? What questions should I ask? Because clearly they're not going to tell me because I just seen somebody get their foot cut off.
Well, I think there's a couple of things, and just to backtrack 1 second, there are some landmark articles that have come out, studies that have come out that compare bypass to endovascular. And basically, in all those studies, you're comparing apples to oranges, because they compared bypasses to people who just had what we call an angioplasty, which is stretching the blood vessel in an endovascular way, okay? But in none of those studies, really, did they have the artery cleaned out. And so you can go way back to the Journal of Radiology that said, well, if you just use a balloon in the artery, within 1 year, you have a 96+% reocclusion rate or, blockage rate again. And then when I opened this institute, I was doing some stenting and cleaning out the artery, but stenting. And the fact of the matter was that, no, you didn't have a 96+% restenosis rate. You had a patency rate that was similar to a bypass above the knee. And I was called on the carpet for that. And with my own data, that kind of made everybody quiet, and we just proceeded along. Now, your question about you're a diabetic, you go in the office, what do I do? Well, number one, I think diabetics not only should have a primary care doctor, but they should have an endocrinologist.
Okay.
And every 3 months, they should be getting what's called an A1C to see how their blood sugar is being managed. And on a yearly basis, they should have an arterial duplex scan, which is a scan of the arteries of the leg. Another test which goes along with that, which is called an ankle brachial index, and toe pressures, because toe pressures are more accurate with regard to blockages than an ABI is. Someone who gets an ankle brachial index, who has a blockage, has a lot of collaterals, it could be normal.
Right.
But the toe brachial index is more accurate, and we use that quite a bit. And if they need to be counseled, and if you get a wound on your foot, you need to get right in and see somebody. You need to be using lotion on your feet so you don't get real scaly and you get skin breakdown.
Okay.
I mean, these are very simple things that the primary care doctor can do.
But I'm not hearing about any of this, because I hear an eye exam, just a visual foot exam, and then the A1C. Other than that, control your diet or exercise. I've never ever heard what you just mentioned.
Yeah,
something
on a yearly basis, they should have an arterial duplex, an ankle brachial index, and a toe brachial index. And that will tell you if there's an issue. Sometimes, that ankle brachial index will be abnormal because the blood vessel has calcium in it. It's non-compliant, so it looks abnormal. But you again get the toe brachial index, and that tells you a little bit more.
Scott.
So Yolanda, it's also very regionally dependent. It depends on who's providing your care, what part of the country you're in, and do you have a vascular provider in the community that's interested in diabetic limb preservation. If you don't, how do I put this? If your only tool is a hammer, everything in the world starts to look like a nail, right? You probably heard that.
Yes.
If you don't have somebody who knows how to use these tools of the ABI, the TBI, the non-invasives, if you don't have that as part of your care team, they don't know how to use those tools are never coming out of the bag.
So
go ahead.
Why this is on my mind. Tell me real quick a little bit about what you guys do at your place, and can people get in contact with you guys if for some reason
mess around and have everybody call us?
Hey, that's what it's about. I mean, I'm already mentally taking these notes to talk to my doctor about. But tell me some of the things revolutionary things that you guys done. But I really also want to recap what the bigger mission here is too, and that's really bringing this focus to the Native Americans. So it's a two-part question. Why do you think that this hasn't? Do the Native Americans really have anybody to speak on their behalf? And if so, what do the United States need to do? What do we need to do as far as readdressing laws with our senators, with the state of Arizona, with the state of Indiana, Ohio? What do we need to do to bring awareness universal, not just to the Native Americans, but to the whole world?
So there is underrepresented at-risk population in the United States that doesn't get as much attention as it should historically, and that population is the Native American population. And it is a large and growing population, but because many of our Native American brothers and sisters and grandmas and grandpas choose to live in the old ways, they are geographically isolated. And because they're geographically isolated, they're underrepresented in the press, on social media, and in the government. What needs to happen, what must happen is celebrate IHS, be happy that it's there, invigorate IHS with funding, and invigorate IHS with the mission of limb preservation, because the number one killer of Native Americans in the United States is diabetes. And guess what, guys? Pretty much the same thing can be said for African Americans. For African Americans, it's diabetes and hypertension, number one killer. Now, in African Americans, how do they die from those two diseases? Stroke and heart attack. Number 3 is major amputation. I would bet that between the two of you, I mean, we already know this is true for Andre, that you either have a relative or a close friend who has had an amputation.
Yeah.
That is true for Native Americans. It is very rare that a Native American of the quote unquote uncivilized tribes out here in the West doesn't have at least a second degree relative who is either on dialysis or has had a major amputation. Unfortunately, the Indian health system, the separate but equal health system, has pursued wellness programs that do not focus on the number one killer, which is diabetic peripheral arterial disease. I did the first ever angiogram at a Native American hospital on May 26, 2014. The first angiogram, meaning where we inject contrast into an artery, we look at that artery, and then we have the opportunity to fix it, to open it back up again.
Right.
2014. Do you know when the first ever angiogram, peripheral angiogram, was performed? It was in Switzerland in 1974. It took 40 years and a kid who grew up on the reservation to get that technology out to the reservation.
You said
amazing. Okay, you going on.
we can wrap up a minute, but I got something that definitely I need to share that me and Scott talked about, and I really love the fact that you and Marc are really building something there for the Native Americans, for even the state of Arizona itself. But what I do like that we talked about was tell the viewers about the ability of regenerating wealth through education. I thought that was so beautiful on you and Marc putting that program together. Can you share with the viewers that concept?
Absolutely. And this is the big mission, okay? We've talked about some very practical stuff about advocating for yourself and advocating for your family. There's a list of to-dos that we have for patients with diabetes after this program. That's firm, that's foundational. Now, I'm going to get aspirational, okay? I'm going to get big ideas. I'm going to get 10 years out, 20 years out. And the way that we are going to solve this problem of Native American disenfranchisement, of generational poverty, of institutional corruption, and of massive limb loss, the way that we will solve this is by investing into the reservations the ability to obtain a world-class education in limb salvage. We are going to establish Limb Preservation Center of Excellence on the reservation. Wow. That has the highest standards of care and training. And the Native American grandmas and grandpas will be taken care of by their Native American grandkids. And my brothers and sisters on the reservation will come out of these centers of excellence with such a reputation of skill, where they know, because they've done thousands of these procedures, this comes first, this comes second, this comes third. And those kids that we train will be so sought after. They'll go to places like Massachusetts General Hospital, Johns Hopkins. They'll go down to Miami Vascular, and they will promulgate the message that we can't have a system that is just hoping to do enough. We got to go totally the other extreme and make it so the system on the reservation is the absolute best, and it's the model for everybody else. And that becomes a source of pride for the tribe. And people recognize, wow, this population took their number one enemy, limb loss, and they turned it into their success.
That's powerful. Wow.
And the one thing I would add to that, I mean, Scott is just
he's pumped up. You know that, right?
Yeah, he's pumped up. You see his arms?
Yeah.
You know, his main focus in large part is the Indian reservations, but you do have disparate healthcare, and you do have it in, you know, African Americans, Hispanics.
Yep.
So all of these disadvantaged, if you want to call them disadvantaged, you know, individuals need to be taken care of. So it's not just the Indian reservations, although that's, you know, that's Scott's, you know, real thing, but it's the other populations too. And there needs to be a change in healthcare, more in the preventative. If you prevent the amputation, you then prevent the potential mortality, but you also prevent patients having to go to skilled nursing facilities, which cost money, rehab facilities, which cost money, prosthetics, which are not cheap. They're very expensive. And you also prevent, in my mind, all of us have it, body image.
Right.
Okay. When I go, I want to go with all my parts.
Mm-hmm.
And I suspect you do too.
Yeah. No.
You know, and the other population that we really haven't talked about are all the people who are on dialysis and have renal failure. They have very bad peripheral vascular disease, and a good number of them, probably the majority, have their kidney failure due to diabetes. So there's a lot to do, and there's many populations that need to be addressed.
Guys, this has been a great show. We're almost out of time, but definitely we're going to have you guys back on the show. We're going to do a follow-up on this before we leave. How can the viewers contact you guys for more information? Because I'm pretty sure you're going to get a lot of people that can relate to what we just got through talking about. How can they reach you guys with questions that they may have?
I don't know, Scott, do you remember the phone number of the office?
I sure do. So anybody has any question, we give you a couple. The phone number is 480-223-1333. Again, 480-223-1333. And I'll give you another phone number if anybody has questions they want to text. It's 480-840-4230.
Go ahead.
We have what's that?
Go ahead.
Yeah. We have a website, modernvascular.com. And we have if you're interested in the Native American piece, there's you can look up on YouTube, the First Nations Limb Preservation Foundation with a video. And there's a lot of national resources. Maybe next time when we come on, I'll be able to provide you with some more regional information. Londa, when you were sitting there telling me about the checklist that you go through for diabetes every year, and it includes an eye exam, right? Yeah. A visual exam. It includes, like you said, a test of your kidneys, usually how the kidney's doing, and then a hemoglobin
A1C.
A1C.
Test your kidney. They don't even test your kidney. Well,
So
I guess if you get the blood work, what do they just look at your creatinine level then?
Or sometimes they'll take a urine sample and look for protein.
Yeah. Okay. So we'll go with that. Okay. We'll go with that.
And that was the same exact system, the goldenrod system that I experienced in IHS, is they had these, sort of benign annual evaluations, eye exam, and nowhere on there was there a recommendation for ABI or for TBI. When we say ABI, TBI, that's basically a peripheral vascular evaluation. Nowhere on that sheet. But even at that time, this is back in 2013, the recommendations from American Heart Association, American Diabetes Association had been published for 13 years at that point. They've now been around for 20 years. The recommendations from those two organizations that every diabetic 50 and older must have a peripheral vascular exam. and you've never heard it.
I never heard of it either.
No, and I can go as far as to say I was a cardiovascular specialist with Merck Pharmaceuticals for 10 years. And we would go in and we would talk about the heart. We would talk about diabetes. We talk about, that's why I'm telling you what I know as like standards of care, right? The standards of care. And I was familiar with PVD, but it was never really discussed how somebody actually got it or what the impetus was there. I never associated that with the diabetes annual checkup. Never.
And let me just guess, your involvement with that industry was probably the late 90s?
I started with them, 98. I tell you what I did. I started heart care partnerships around the country, and our drug was Zocor at the time. So if you know Zocor, for cholesterol, it was a big drug at one point before Lipitor showed up.
Right.
And we would do that. But I'm telling you, never. And then I had Cozar, Hyzar, and one of those drugs, I don't even remember, or Zocor, one of them showed the risk of stroke being reduced in diabetics, which is why we got laser focused on the diabetes population as well. Also understanding that people with diabetes would then succumb at a high level. I think it was, I don't know what the rate is now, it was like 70-something%, wasn't it, from heart disease. They would die from heart disease or whatever.
Exactly. Now, what you have to realize is that even up to the late 90s, we were still catching up with this diabetic epidemic. We still didn't realize how bad things had gotten, right? Because hemoglobin A1C as a standard monitoring tool didn't really come into existence until around 2002, right? I mean, it wasn't available like it is now. And when we started doing that, we started realizing, oh my gosh, this patient has had severe disease for a very long time.
Well, and we were taught that by the time you were actually given a frank diabetes diagnosis, you had 10 years of damage.
Exactly right. And so we have this epidemic that really begins in 85. People don't even know anything's wrong until 95, 96, 97. We're starting to pick up on, oh, whoa, hey, this is more than just high sugar. This is having consequences everywhere. And it's not until 2012 that we have the first articles coming out about diabetic revascularization, right? And so you have an entire generation of surgeons that are trained to treat vascular disease that's based on smoking and hypertension and high cholesterol. An entire generation up until 2012 that's treating that disease.
Yeah.
And now diabetes happens, right? And it's not because those guys are bad. They're great. And they're great at treating that disease that they were trained to treat. But literally the earth shifted underneath them. Everything changed. And it changed in a way that we have not seen historically. Massive epidemiological changes like this generally don't occur in this punctuated fashion. The fact that high fructose corn syrup was introduced across the industry and then increased and increased and increased created a situation that's almost unprecedented in modern healthcare and has taken a long time for people to adapt. And that's why we're struggling to get this information out there, because what people know prevents them from learning.
That's scary, but the other flip side of it is that if there could be some impact then on the education system as to these new healthcare professionals coming in and being taught differently, maybe that can, this is one of those things, if you ask me, you're going to have to hit it at multiple angles. That's all it is to it. There's not going to be a cookie cutter approach to it. It's going to have to, you got to go through education. You got to go through the training of the healthcare professionals. You've got to go through somehow knocking these guys over the head that just want to think very one-dimensional and say, hey, we've got to be taking a look at this. Or how do you get somebody convinced enough that the guidelines at least need to say a vascular workup is mandatory, it's necessary before you're allowed to just amputate somebody's leg. I don't know. You guys got a tough fight ahead of you, no question about it, because I know how rigid the system can be, and I know the politics, and I certainly know by working for a pharmaceutical company how the money comes into play. So,
well, they don't want to extend life anyway. Because that's going to cost them the insurance industry more money the longer that you live.
so this is where it gets funny. It costs the insurance company more, so they don't want the cost, but the pharmaceutical company, there's no money in the cure. So they do want to extend life and keep them on the drugs forever and ever. So you've got competing priorities coming from different areas. And then you got diehards like these guys who said, look, we're all about preserving life. We want people to live. We want to do the right things. And they're telling them, hey, we're going to penalize it. And if you're not right, the way it used to be, the whole performance index of how you got paid, you'd get penalized for doing too much and doing the right thing. It's tough, guys. I get it. It's tough. But hats off to you. I'm telling you, I have great admiration.
Before we do the teaser, I got to ask Scott and Marc a question.
I'm just sitting here with my head.
I had a stroke due to a cortisol injection. It started out with hiccups. I wound up with neurological problems because I had hiccups for 30 days. Went to the hospital. They wouldn't do nothing about it. They wouldn't address the issue. I was already in pre-stroke mode by the time that they did it because my left side was hurting. I was still working out because I thought it was just lifting too much weight. So I just kept hitting it. My eye drooped the whole 9 yards. I lost a little bit of my memory from it, but my question is, I'm more nervous now because I don't know what to ask the doctors as far as follow-up.
So the follow-up that you need a hypercoagulability workup, okay, to look for genetic factors that would predispose you to forming a clot.
That's me. Okay.
You need an echocardiogram to make sure that you don't have some type of an abnormal connection between the right and the left side of the heart, right? Okay. You need an EKG, probably an EKG monitor to make sure that you don't have AFib. AFib is one of those things that affects big muscular guys like you. Yeah. And you may have some element of hypertrophic cardiomyopathy, which can contribute to AFib. So you need those three things: hypercoagulability workup, echocardiogram, EKG.
Mm-hmm. I'm gonna hit you up with the text later on that.
Definitely.
Yeah, because I mean, it really freaks me out because I already been diagnosed twice with is it called angina or something?
Yeah.
It's like you're having a heart attack and stuff, and it registered as having a heart attack. And I was like, what are you talking about? And they said, but because the years of lifting, my heart is so strong. I was actually used to live in Cleveland, Marc.
Oh, did you?
If I'm late, yeah, I used to pass that area all the time.
I'll tell you something funny, but first off, the other thing you need is a carotid duplex to see if you have any blockages in your carotids. But when I was in Cleveland, when I was 40, a long time ago, I used to go to the gym all the time. I did powerlifting.
Okay.
And I was working out with a firefighter, and we were doing bench press. And I had decided that day, okay, I want to see what my max is. And I weighed 150 pounds.
Okay.
Georgie.
And so I went right up the scale, and I finally benched that day, because I was just doing one for each weight class, 300 pounds.
I was going to say 300.
And everybody went wild because it was like, you're the strongest dude in the gym. You just bench press twice your body weight.
Right.
And I used every muscle in my body. I even used my toes. But that's when I was in Cleveland. Anyway, so you should get a carotid duplex.
Okay.
And everything else that Scott said, absolutely you should get.
Okay.
And if you're having symptoms of angina, chest pain, you might even want to get a nuclear stress test.
Well, I'm having problems right here, but I think it's because I had spinal fusion. The same people that did Peyton Manning's did mine, and I have to go back because the lady who did the surgery, Dr. George, she was good with the surgery, but she wasn't good with the aftercare. So they never asked me the most crucial question: what do you do for a living? So they was like, well, go back to work. So I'm going back in there throwing 200-300 pounds around. I damaged the next nerve, spine. So now they just set my appointment up with another doctor. So then I have to go back in and refuse another spine, which naturally, the more spines they fuse, the weaker your core is going to become. So I'm having a lot of pain right through here. So I didn't know if maybe that was probably from this or if it was from the stroke, but I'm going to write that down and give it to my doctor and say, look, this is what we need to check out.
Appreciate it. I think this is a lot of information. Sounds like there's a heck of a lot still to do, but I always say, how do you eat an elephant? One bite at a time. So I think, you establish one center, you show remarkable outcomes. Hopefully you guys can get the traction you need to be able to do this all across the country and throughout the world, because there's a lot of diabetes in other countries as well. So,
well, guys, I hate to say it, but Tag, you're it. Yolanda, you've heard the message. You're responsible for it now. Andre, you've heard the message. You're responsible for it.
I'm getting ready to pass it around.
Go forth and spread the gospel of limb preservation, please.
Absolutely. Yes.
Guys, thank you for being on the show. This has been another exciting episode of the Andre the Beast Crayton